This technique video describes combined distal tibia and talus allograft reconstruction of bipolar glenoid and humeral head bone loss for recurrent anterior shoulder instability. These are our disclosures. The patient is a 22-year-old female with prior history of right recurrent anterior shoulder instability. Due to the significant bipolar bone loss and recurrent instability despite non-operative treatment, she was indicated surgical intervention. Pre-op imaging revealed 25% anterior glenoid bone loss and a large Hill-Sachs defect measuring over 15 millimeters in width and 30 millimeters in height of the humeral head. With the arthroscope in the posterior portal, an anterior portal is established under direct visualization and a cannula is placed. Arthroscopy confirms no anterior inferior labral tissue was present and confirms significant anterior inferior glenoid bone loss. A standard deltopectoral approach with a subscapularis tenotomy is performed. The Hill-Sachs lesion is then identified on the postero-superior aspect of the humeral head. A fresh talus allograft is measured and utilized for the humeral head osteochondral grafting. The graft is then held over the defect. Once the graft is appropriately positioned, 3 K-wires are placed to provisionally hold the graft in a reduced position. These are the same K-wires that will be used for screw fixation. 3 3.5 millimeter headless compression screws are placed to fix the graft. It is important to note that these screws should not be bicortical to avoid anterior soft tissue irritation. Attention is then turned to prep the distal tibial allograft. Using the Arthrex distal tibial allograft workstation, a 10 by 15 millimeter graft was cut to replace the glenoid bone loss. A 10 by 15 millimeter template was chosen based on the glenoid bone loss in the patient's anatomy. Next, a K-wire is placed into the allograft to use as a joystick for ease of placement and fixation. Attention is then turned to the glenoid reconstruction. The humerus is reduced and the anterior glenoid surface is exposed with an anterior Bankart retractor immediately on the glenoid neck and a Fukuda retractor laterally to retract the humerus. Once the graft is positioned, the K-wires are advanced to provisionally fix the graft. The graft and glenoid are drilled and measured. 2 4.0 millimeter cancellous screws with washers are then used for fixation. After copious irrigation, the anterior capsule was repaired using the suture washers loaded with number 2 fiber wire. Following capsular repair, the subscapularis tendon was repaired with 3 fiber tapes and 3 4.75 millimeter peak swivel lock anchors in knotless fashion. The rotator interval was also closed with number 2 fiber wire sutures in figure 8 fashion. A standard layered closure is then performed.